So good afternoon, everyone. And my name is Dr. Pamela Jo Johnson. I'm the chair of the NDSU Department of Public Health, and I would like to welcome you to the Fall 2020 NDSU Public Health Seminar Series. So this seminar series is an opportunity for our department to share some of what we're working on, as well as occasionally bring in outside speakers to address timely public health topics. So this fall in public health, we're currently all about COVID. And so our fall seminar series is going to provide a number of unique perspectives on the COVID situation, including seminars on COVID-19 controversies and misinformation, systems thinking approach to pandemic management, and a legislative perspective. We also have a very special event on Tuesday, October 20th from 2 to 3:30, so please mark your calendars. More information will be coming. But we are co-sponsoring a panel with NDSU's Challey Institute for Global Innovation and Growth. And we are going to be bringing in three renowned speakers from across the country to address the question of how does society reclaim human flourishing in the face of a pandemic. And so we are bringing in Dr. Ali Moqdad, who's a population health expert, Stephanie Hafele, who is an economist, and Dr. Lynn Blewett, who's a health and social policy expert. And our fall seminar series will be taking place every other Monday, approximately, from 3 to 4:30, except for some special events. And so now I would like to turn things over to Dr. Andrea Huseth, who's going to introduce our first public health seminar of the fall.
Well, welcome to our first seminar. This is very exciting. The title is COVID-19 Case Investigation and Contact Tracing in North Dakota, Experiences from the Field. The seminar will be a panel discussion moderated by Kylie Hall and will feature several other experts from North Dakota in the area of contact tracing. Kylie Hall is currently the project manager for the NDSU Center for Immunization Research and Education. She has a bachelor's degree in microbiology and received her Master of Public Health from NDSU in 2015 with a specialization in management of infectious disease. Ms. Hall helped launch NDSU's contact tracing efforts this past spring, serving as a case manager for NDSU students that were assisting the North Dakota Department of Health with COVID case investigations. She continued in that role until July, and she is excited to moderate the panel and highlight the experiences of COVID case investigators throughout the state. I will now turn the discussion over to Ms. Hall, and she will introduce the other individual panelists.
Perfect. Thank you, Andrea. And thank you all for joining us today. My name is Kylie Hall, like Andrea said. Today, I'd like to start by introducing our panelists. Then we're going to talk briefly about the steps of case investigation and contact tracing. And then I have a series of questions that I have ready for our panelists. We are hoping to have some time at the end for audience questions. So as the seminar progresses, please feel free to type those in the chat box, and Dr. Andrea Huseth will be monitoring the chat box. Before we get started, I do want to remind everyone, please make sure your microphone is muted. And I also want to let everyone know that the seminar is being recorded and it will be available at a later date for viewing. So let's start with introducing our panelists. Our first panelist is Tasha Peltier. Tasha is Hunkpapa Lakota and a member of the Standing Rock Sioux Tribe. In 2016, she received a master's degree in public health with a specialization in American Indian Public Health from North Dakota State University. She is currently employed by Quality Health Associates of North Dakota, which is part of the Great Plains Quality Innovation Network that serves North Dakota, South Dakota, Nebraska, and Kansas. Through her work and personal experiences, she has also developed a particular interest in exploring ways to provide culturally relevant approaches to achieving overall health and wellness. Most recently, Tasha has been contracted by the Standing Rock Sioux Tribe to serve as their COVID case manager to oversee case investigation and contact tracing, navigate resources for families in isolation and quarantine, identify hotspots or large-scale exposures, address non-compliance with law enforcement and compliance officers, and serve as a point of contact for the North Dakota and South Dakota Department of Health. Next is Brenton Neesmeyer. He is the field epidemiologist supervisor for the North Dakota Department of Health and has been the regional field epidemiologist in Cass County since 2017. He is based at Fargo-Cass Public Health. He graduated with his bachelor's and master's degrees in microbiology from North Dakota State University. Next is Faye Salzer. Faye is a registered nurse who has been working for the North Dakota Department of Health Division of Disease Control since 2009 as the Healthcare Associated Infections Coordinator. Faye is also the Antibiotic Stewardship Coordinator and Infection Prevention and Control Coordinator. She has 36 years of nursing experience in various areas of healthcare, including nursing administration, long-term care, and in the operating room. She's currently assisting with investigation and analysis of disease clusters and outbreaks, including the COVID-19 pandemic. Our final panelist is Shawn McBride. Shawn is the North Dakota Department of Health's regional field epidemiologist based out of Grand Forks, and he's been with the North Dakota Department of Health Division of Disease Control for 9 years. He has a Bachelor of Science in Biology and a Bachelor of Arts in Psychology from the University of North Dakota. His role as a field epidemiologist has led to many interesting and eventful experiences around the investigation and intervention of communicable disease, one of the most notable being the 2012 tuberculosis outbreak in Grand Forks. So those are our 4 panelists. Thank you all for being here. And in just a moment, we'll get started on questions for all of you. I did want to briefly go over case investigation and contact tracing to give all of us a foundation of what it is that we do in public health. So it all starts with a positive COVID test. So in North Dakota, COVID test results are reported to the Department of Health from either the state lab or another public or private lab like a healthcare system. Once the Department of Health is notified of a positive test result, the case is assigned to a regional case manager. The case manager assigns the case to a case worker who is in charge of conducting the case investigation with the individual who has tested positive for COVID. During the interview, the caseworker gathers information about the case, such as contact information, medical history, things like when symptoms started. The caseworker provides instructions to the case regarding isolation and how to seek medical care if it's needed. The caseworker also gathers a list of contacts that the case had during their infectious period. So COVID-19 is unique in that you are contagious before you show symptoms, and we refer to that as pre-symptomatic. Because of this, cases are asked about the day their symptoms started, and then we gather contacts 48 hours prior to their symptom onset. So as an example, if somebody remembers that their cough started on Friday of last week, we would gather all close contacts 48 hours prior, so Wednesday and beyond. We define a close contact as anyone who was within 6 feet of the case for 15 minutes or more. When the interview is complete, the caseworker will get the case set up for daily monitoring via phone or email and let the case know a tentative day when they'll be released from isolation. Isolation is a public health practice that separates sick people with a contagious disease from people who are not sick. So for cases, they can be released from isolation once 10 days have passed since symptom onset, as long as they haven't had a fever for 24 hours, and they also have to have symptom improvement. Once the case investigation is done, the case worker or another contact tracer begins contacting all of the case's contacts. So the contacts are notified of their exposure. The Department of Health recommends that they be tested 7 to 10 days after their exposure, and they set them up for daily monitoring. The contact tracer also provides education and information to the contact to help them understand their risks and the possibility that they could spread the infection to others even if they themselves do not feel ill. The contact tracer reviews how to self-quarantine and talks about what their quarantine period is and how they should seek medical care if they need it. Quarantine is different from isolation. So quarantine separates and restricts the movement of people who were exposed to a contagious disease to see if they become sick. So isolation is for people who have COVID-19. Quarantine is for individuals that have been exposed to COVID-19 and they need to limit their contacts in case they go on to develop the disease. For COVID-19, the Department of Health recommends that exposed individuals quarantine for 14 days after their last exposure and then monitor themselves for symptoms of COVID. So why do we conduct the case investigation and do contact tracing, and does it work? In conjunction with other measures that we have to reduce the spread, specifically, masks, social distancing, contact tracing helps us interrupt the transmission of the virus and slow that spread. If we can isolate people that have the virus from people that don't have the virus, we can slow or stop the spread. And similarly, if we can quarantine individuals that have been exposed so that if they do develop the disease, they've had minimal or no contact with others, that's another way to slow or stop the spread. 2 things in particular are making this virus hard to control. First is that some people have asymptomatic infections, meaning that they never show any symptoms and may not know they have the disease while spreading it. And second, a case is considered contagious before they show symptoms, which I mentioned earlier we call pre-symptomatic. Individuals may infect others while they still feel healthy, and they will go on to develop symptoms later. All right, lastly, I'd like to end by giving you all an update on where North Dakota currently stands related to COVID. Our first case in North Dakota was reported on March 11th, and as of this morning, 15,831 cases of COVID have been reported to the North Dakota Department of Health. And you can see the county by county ranking up above. The darker the colors, the more cases that have been reported in those counties. One thing to note is that the darker counties on the map are also some of our largest population centers. Just something important to note. So I will stop sharing my screen and we will get started on our questions. So Brenton, my first question is for you. On May 7th, NPR published an article stating that North Dakota was the only state that currently had enough contact tracers to handle the pandemic response. So Brenton, can you tell us about how the North Dakota Department of Health went about building a contact tracing workforce, and how has your team of contact tracers grown in the last 6 months?
Thank you, Kylie. Good question. So the North Dakota Department of Health realized early on through seeing reports nationally and internationally of how important contact tracing really was in the response. But the division is disease control, the division that Shawn, Faye, and myself currently work in, is a fairly small division within the North Dakota Department of Health. We only have about 30 employees on a good day, so we are fairly small, and we're 30 strong, so we do everything for reportable conditions. So we quickly realized that, due to the large influx of cases that we were expecting, we would not be able to handle the sheer amount of contact tracing and case investigation that needs to be done. And I'm just going to touch on that real quick. Case investigation and contact tracing really are two separate things. Case investigation is investigating the positive case. Contact tracing is identifying and quarantining those contacts. So we realized that, this isn't something that 30 people can do. So we went out to our local public health units, our local colleges, UND and NDSU. We utilized internal disease control staff and other staff within the health department and brought them up to speed on what contact tracing and case investigation is really about. Initially that training was, one-on-one training. We kind of talked about it. Most of us within Division of Disease Control have had vast experience doing investigations with other diseases such as E. coli, pertussis, or STDs such as syphilis, HIV, gonorrhea. So we felt fairly confident in quickly learning what a case investigation is, but many of the people who we brought on had never done a case investigation. So we did, hands-on training, and we still do that training, but we now have our case investigators and contact tracers go through about a 1 to 2 week shadowing / training / a little bit of everything before being brought on as a case investigator. This training includes watching the Johns Hopkins training. The Johns Hopkins Institute put out an excellent training that's about 6 hours long that really goes through the steps of case investigation and contact tracing. We have them watch our internal dynamics videos and internal mock interviews just to kind of see how we do it, because it is helpful to have that mock training and watch our systems because they're going to be different than across the nation. After they have completed those trainings, we bring them on and have them shadow some of our caseworkers or shadow a case manager. And this is really important because they really get that live experience and listen to someone who is experienced do this case investigation. And then after they go through the shadowing, where they may shadow 1 or 2, do a couple contact calls and shadow a couple contact investigations, we listen to them do a case investigation so that we can see how comfortable they are with us in the background, listening very silently to see how they do, and then provide pointers to them after that. So it is kind of a team effort. It does take time, but it is important to have people who are confident, people who are skilled, and people who are comfortable doing the case investigation before setting them free. You know, I said that we started with, 30 disease investigators or contact tracers, because everyone in North Dakota Department of Health Division of Disease Control kind of really stepped it up at the beginning, and we were all doing case investigations. You know, now I would imagine that we have close to 300 with UND, local public health units, state hired contact tracers, and NDSU, along with disease control, all being brought on to do these case investigations. So we're always bringing on new staff. So if you have free time, this is my plug, free time, think about working for the North Dakota Department of Health, NDSU, UND, and do some contact tracing. So that kind of is what we did and how we upscaled it. And thank you, Kylie.
Yeah, thanks, Brenton. That was great. So increasing our contact tracing workforce early was critical, as an increase in cases was inevitable. So Shawn, my next question is for you. You were the case manager for a large workplace outbreak in your region. Can you tell us a little bit about how the outbreak was identified, how mass testing events were coordinated, how the outbreak was eventually brought under control, and then just share any lessons that other workplaces can learn from this outbreak?
Hi, Kylie. Thank you for that question. Yeah, I was the unfortunate recipient of a large workplace outbreak in middle of April. What we first had noticed was there were a number of cases, workers who'd reported onsets that were, their symptoms had started within about 3 days of each other. And so at first, we thought we have cases clustered in space and time here. And what may be happening at this workplace, since that was the common factor tying them all together. At that point, we felt there was something kind of significant occurring and began to just kind of at first make the appropriate notifications. At that time, we hadn't brought on a lot of outside caseworkers. I think disease control's first step in expanding our contact tracing workforce was to try and get local public health ramped up to do that work. And so we had, kind of completed that process. And so it was tying in local public health, letting them know what we were seeing and to be prepared for potentially an outbreak in a number of cases that we would need to start investigating. It was talking to the state and coordinating, what our response would be, which, was quickly determined to be that we need to do some type of a large scale testing event to get our hands around what is actually happening here. I've often said many times that when we identify an outbreak, that outbreak has already occurred. And so by the time we identify it, we're really playing catch up. And part of that catch up is trying to understand how widespread it is and how many people are impacted. And so there was planning coordinated with the North Dakota National Guard, which was really integral to a lot of the large scale testing events and being able to respond to things that had occurred around the state and ramp that capacity up because again, local public health was tied up in contact tracing and case investigation work, as well as assisting with testing. They just did not have the capacity to respond to and do a large scale testing event of the size that we were talking about, which was, testing 1,000 individuals in a single, probably a single day. From there, we looked, there was also a survey administered to the workforce to try and understand what factors may have been contributing to the spread within the workplace, asking about their PPE usage, asking about social distancing, other mitigation factors, to try and determine, are there some things that connect cases, or are there some things in the workplace that were protective? And so that survey was administered at the same time to also identify symptomatic individuals who may not have been tested yet. And then within the following week, that testing event was done. And in response to this, the workplace also decided to close for 2 weeks. I think this was an important step because at that time we did not know how many individuals were impacted, and we needed to act proactively to potentially prevent further exposures, not only in the workplace, but in the community. One of the big concerns initially was that if we didn't have an adequate response, we could have kind of an ongoing transmission within this workplace, which would serve as a reservoir for the community and constant community introductions if we couldn't get our hands around the cases here. So I believe hopefully that answered kind of the response part. The initial testing identified an additional 85 people that were positive in that first round of testing, which was in addition to the 9 that were identified independently through diagnostic testing at the hospital. And then there were a number more just throughout the next week or so that were identified at healthcare. And then in a follow-up testing, there were another, I believe, maybe 70 some individuals identified in that workplace outbreak.
Perfect. Thank you, Shawn. Very interesting. One industry that has been the center of attention during the COVID pandemic is long-term care facilities. In North Dakota, staff and residents in long-term care facilities are regularly tested for COVID to help identify cases and quarantine close contacts. For months, North Dakota's long-term care facilities were closed to visitors. So Faye, as North Dakota's Healthcare Associated Infections Coordinator, what have you noticed about cases that turn up in our long-term care facilities? Is there anything specific that comes to mind that you'd like to share about contact tracing in our long-term care facilities?
Thanks, Kylie. Actually, as a state, if you are following our long-term care case counts, we did really well with keeping it out of our nursing homes. And unfortunately, they were quarantined and kept away from loved ones for that person-to-person other than virtual visits and window visits. But what we're seeing as we increased that openability, so to speak, where we had family coming in, as well as the community onset increasing, we noticed, and usually high percentage of the time, we would have a positive healthcare worker in the facility before we'd have a positive resident, or we would see them both at the same time. And basically our biggest message out there, our state is open as well, is what you do outside of work does affect where you work, especially with the vulnerable population. We really stress the use of masks and source control out in the public because of this, because you are infectious 2 days before you have symptoms or before you receive that positive test. And yes, we do wear a lot of PPE or personal protective equipment as mask and eye protection and such in our long-term care facilities. The point of the matter is, it's not 100% guarantee that you can't transmit that infection. It reduces the risk, just like when you wear a mask out in the public, it's reducing the risk, but there is no 100% guarantee. And so it's just shown that we have an outbreak in the community, and all of a sudden the nursing homes in that community have positive cases, and you'll see a large number of healthcare workers as well as the residents. And so that's what we've been finding with that. We've also had encounters of where family members, the same again as the staffing, you need to really enforce all those source controls. We don't want people to stop living, but we want them to be living smart, so to speak. And so wearing that mask, keeping that social distance, avoiding that large group activity, basically staying with your personal pod so that you're always exposed to the same type of people and that they're doing source control too. Because we've had many family members, and the number keeps ticking up as the community numbers keep going up, where they need to notify us that, they went to see their grandma or their sister or, their mom, their dad, and then unfortunately a day or two later, they test positive or they start to have symptoms. And so we don't want to go back to, closing everything up, because yes, it was very hard on our residents, but having these numbers in the facility and the numbers going up is also very stressful for the residents because even though our state is opened up, when we have those kind of numbers in our nursing homes, they then have to be quarantined or isolated in their rooms anyway. So it's almost like they're back to the closed in lockdown type feeling. So that's really an important thing to realize is, you know, you can still get COVID with your source control, but each time we add a layer of source control, it decreases that risk. And that's really what this is all about. So, you know, wearing that mask is one layer, then social distancing is that second layer, and being smart about where you're going is a third layer. And so as we continue to add that layers, our risk drops down. And I think that's really an important instruction to get out there to the community, is we're not trying to control you with mandates here and there. We're just trying to make you think about your choices, because even if they aren't in a long-term care setting, you may have a grandparent, or in my family situation, somebody immunocompromised or going through chemo, where you don't want to have that risk for them. So it's all about us being smart, responsible, and decreasing that risk.
Thank you, Faye. Tasha, my next question is for you. You were chosen by the Standing Rock Sioux Tribe to be their COVID case manager. Can you talk about why Standing Rock wanted a case manager designated for its citizens, and what are some of the unique challenges that you've had to address in your position?
Sure. Thanks for giving me the opportunity to come on and talk a little bit about this. I think early on, as Brenton was talking about, the Department of Health kind of beefing up the contact tracing and case investigation capacity, I was brought on through my organization, Quality Health Associates of North Dakota. And early on, I offered or recommended maybe having individuals specific to work in tribal communities, just because working with those communities, I know there are different government structures, there's different programs available. And so when you showed that slide in the beginning, kind of the process of that case investigation and contact tracing, knowing that there's maybe different process, not necessarily different processes, but different organizations that are going to assist in those processes within tribal communities, I thought, you know, that's probably a good idea to have individuals like that. So that conversation led to another. And then as I was working with Standing Rock, it was kind of like, okay, what can we do to kind of lock you in as being our case manager to work specifically with our cases? And so that started probably in June. We finally got all of that solidified. And then we started to see the cases increase and quickly recognize that we really needed to have people that were navigating through some of the issues that we were seeing. A lot of the things that we know have already existed in our tribal communities are being magnified through this pandemic. So issues like housing shortages are causing issues when it comes to isolation or quarantine. We still have homes without running water. That's a big issue when you're talking about trying to reduce the spread in tribal communities. You know, transportation, lack of access to phones, those things all make it very difficult to do case investigation, to trace contacts, and also to monitor throughout their quarantine or isolation period. And so I think it was a good step. I think it was something that was necessary. But as over the last 3 months, I think we've really figured that it's kind of a big take. I guess it's more than I thought when I stepped into this role. It's definitely more than I expected. So we do have a lot of ways that we've been trying to deal with that. One of the things that we've done is started working with the community health representatives, which has been a super great partnership. So when you talk about having people that know the communities, they're from those communities, they know the people, you know, I'm from there and I feel like I know the communities, but they know everybody, they know everything, they know who lives with who. And so when we have issues of finding people or getting a hold of them or knowing, you know, even kind of figuring out how that spread may be happening, they're really helpful. So to have that is such an asset to our team. And so that we're slowly getting them incorporated. They've been trained through Johns Hopkins, and they've also done the Department of Health training. We're just getting some equipment access for them so they can start to cover nights and weekends. But that's going to be a really huge asset as we move forward in trying to contain the spread within Standing Rock. The other thing that we recognized early on is that, and this is something that we see quite often with Standing Rock, is that we're spread across North and South Dakota. So essentially you're working with 2 different departments of health. You're working, I mean, you just have to double the amount of partnership and coordination. And also you're looking at 2 different maybe approaches to the pandemic. And so trying to figure out what's going to fit for Standing Rock. And I think early on the tribal council did say that they were going to follow North Dakota, all North Dakota's recommendations. So anything regarding quarantine, isolation, testing, all of the recommendations that North Dakota was making, the tribe went on record to follow that. So that's kind of what we've been doing. But still on the South Dakota side of the reservation, the Department of Health does do that contact tracing and case investigation. We're slowly getting into helping with that. It's just that we have 2 different systems, and we're not quite there yet, but it does pose difficulties. You know, when you talk about having another, I guess another Department of Health do the investigation, we have to wait for that process to happen. And so I don't know if everybody's been paying attention, but there's been a huge increase in South Dakota as well. And so they're bombarded, and sometimes, you know, there's a few day turnaround for that, you know, so they have to be notified by the facility, then the state has to enter it in their system, and then I have to wait to get a report from them. So that gets to be a few days sometimes. And so I think our local government would like that to be a little bit faster, and they want to be a little more hands-on. And so we're working to try to get some agreements in place, or just some ways that we can increase that notification, whether that's directly with the facilities that are testing, because this is typically off-reservation testing that happens. When the testing happens on reservation, I know right away. I mean, I get an immediate phone call, so there's no issues there. It's just when they're in the bordering communities, that process is a little bit slower on the South Dakota side. North Dakota, it's easy because I have access to the system, and so I get notified right away. So, and then I think, yeah, I think that's pretty much, of course, there's a lot of issues that we see, but there's a lot of good things. Like I said, the CHRs are a great asset, and so we're just taking it as it comes.
Thanks, Tasha. So Brenton, I want to switch gears and hear from you about your work to address COVID-19 in the homeless population. Homeless services are often provided in congregate settings, which we know can facilitate the spread of infection. And many people who are homeless are older adults, and they have underlying medical conditions, which puts them at increased risk for the severe COVID illness. So can you talk a little bit about how public health and other agencies work to identify cases in this population? And then also talk about what pieces needed to be in place so that we can effectively isolate cases and then quarantine their contacts.
Okay. So nationwide, we quickly realized that COVID not only affected our residents and long-term care facilities, but also negatively affected our homeless population, which, like you said, is more susceptible or more vulnerable to the severe consequences of COVID. I can't be an epidemiologist without throwing a little bit of a stat in there. You know, just in Cass County alone, about 78% of our cases have occurred in long-term care facilities. So a vast majority have occurred in long-term care. But next would probably be our homeless population, or deaths, sorry. 78% of our deaths have occurred in long-term care facilities, but our next proportion would probably be amongst our homeless population in Cass County. And it is because they often have, you know, unintended consequences. They may have conditions that they haven't been regularly seeking medical care, so then they are more susceptible. And what we did when we started getting a few pockets of homeless cases in Cass County, we realized that we may have more of an issue here. So we worked with DHS as a state and locally to identify quarantine hotels in each of our 8 major cities, and where we could effectively isolate and quarantine people who were either COVID positive or contacts to COVID. We also had to have many different things into place for this to work out. Some of our homeless population may have some addictions that they needed support for. They may have been coming off of a high, or may have needed some medical assistance. So we had to have nurses on site to be able to assist those people when those situations did arise. Many of this population does turn to tobacco products or nicotine for help. And we also help provide them, especially in Cass County now specifically, we worked with Southeast Human Services to help provide them Nicorette gum and other nicotine replacement therapies. We worked with our mobile outreach within our community or our Gladys Ray shelter to help identify the people who were positive and where they were at. Because, you know, some of the difficulty is finding the homeless people, finding the homeless population after they've tested. They may have gone to the emergency room, they may have gone to a walk, and they may have gone to one of our free testing sites that we had set up at our homeless population centers, like New Life Center or Gladys Ray or the YWCA. But after a day or two had passed, it was trying to find them and talk to them about why you should come to the hotel and why your contacts, you should help us work with your contacts. And part of it was building that trust in the community. Our mobile outreach, or people who work with our homeless population day in and day out, have that level of trust with our homeless population, that they trust, our homeless population trusts them, they go to them, they may be their best friends, and they're the ones that are more willing to talk to than, you know, one of our case investigators or our contact tracers. So we worked with them to identify who their contacts were and when their symptoms had started. Oftentimes, since being a poor historian was something that we did see when we were putting our population into the hotel, we would quarantine them for 14 days once they got to the hotel, or isolate them for 10 days once they got to the hotel, just to make sure that we were gathering or quarantining and isolating them long enough. Let me go, you know, eventually our numbers dropped amongst our homeless population, and now DHS has turned that control over to the local health units. So now our local health units across our 8 major cities or across the state are working closely with their local public health units and identify hotels and identify these quarantine supports and help do meal delivery, help provide any other essential services that this population may need, because ultimately they are human, they are our citizens, and we care about them too, and we want them to have the same level of care as you and I would. And, you know, it's through the efforts of local public health, state government, our local medical officials, and our contact tracers and case investigators that we're able to do this and provide the support that they need. I think
Thanks,
that
Brenton.
answers that.
Yeah, absolutely. Absolutely fascinating. Shawn, the next question is for you. Another setting where we've seen a number of cases, especially as of late, is our university settings. In particular, the news has focused a lot on cases in fraternity and sorority housing environments. I'm wondering if you can speak to any patterns that you're seeing in our university settings.
Once I get my mic unmuted, I can. Yeah, I think UND had recently experienced what I would classify as an outbreak among Greek housing members. And the contributing factors to that outbreak are really things that I think Faye touched on, or that we see impacting workplaces as well. I mean, with COVID generally, and I failed to kind of talk about, I told you what happened with the workplace outbreak, but I didn't mention a lot about the intervention steps. So I'm going to go just back through those a little bit, and then I can talk a little bit about how some of these things weren't in place as well in say, congregate living like Greek houses. So with the outbreak at the work site, many of the intervention things that workplaces can do are things like scheduling breaks, or so that you have kind of the same functional group taking breaks together, where you don't get a lot of personnel crossover that would make other shifts or other work sites exposed to, say, workers that they may not normally work alongside, to kind of limit the impact in the workplace. Doing a great job about educating on mask usage, other prevention measures, hygiene practices, things like how outside interactions can put the workplace at risk, and things of that nature. And what we saw happen at the Greek housing, it seems that unfortunately it was business as usual. And the Greek life does, you know, that's major selling point is the kind of social interaction and the between the members, and the type of housing where it's a large household. They share meals together, they have activities and meetings they do together, and all of these things mean that you're going to have a large number of people congregating together. And if you have cases of COVID in those congregate settings, especially indoors, you can find yourself with a lot of people being exposed. And Grand Forks Public Health did a lot of really great contact tracing around the cases that we saw. And what they were able to identify was a couple limited introductions into the housing that was identified through, the outbreak was identified through the surveillance testing that happened at the start of school. But because of the schedule, a lot of the Greek members had been on campus probably the week or 10 days prior to that surveillance testing event. And there were a couple cases that had onsets or their infectious period started around that time when people began to move in. And what you saw is these individuals had exposed others, or they themselves had contact with multiple houses that exposed others, and then spread to the house members through social gatherings and just the normal activities that occur with Greek life. Things that I'm hoping that they can look at implementing here is looking at, if they can have some more defined groups or cohorts, that they don't have so much crossover between the entire house. If they want to limit the impact of a case on the entire house, if you're going to have meetings, look at new and creative ways to have those meetings or do those activities in ways that would reduce the risk. Unfortunately, we're not in a place where we can have business as usual. And what happened there is the Greek life kind of continued as business as usual. And we saw a pretty rapid spread over the course of 10 days, impacting a large number of the students, resulting in, unfortunately, kind of entire house quarantine. And the reason the whole houses end up quarantined is because there's a lot of kind of indefinable exposures and interactions happening where you really can't say with any confidence that members of the household may not have been exposed when you have shared space, like shared common rooms or kitchens or shared bathrooms. These are all things that lead to just kind of an indefinable amount of overlap and exposure and contact. And so if the houses look to plans at how they can reduce those types of overlaps and things, I think there can be at least limitations in the amount of people being exposed or having to quarantine or isolate as a result of cases in the households. And the same thing happens in workplaces as well. If you can kind of reduce the overlap among different work groups, it can limit the impact on the overall operations of the business.
Yeah, absolutely. Thanks, Shawn. Faye, my next question is for you. One area that people might not think of when they think about contact tracing is the healthcare setting. So somebody walks into the doctor, tells them they're not feeling well, they get a COVID test, then they go home. Can you walk us through that contact tracing process when people visit the healthcare system?
And my group works with every single positive case in the state. So when the caseworker does their investigation, they will notify us if they identify any medical appointments or if they've visited anybody in the long-term care setting, or even if they've visited a patient in the hospital. So we get all that information, and then we reach out and we start our internal, so to speak, of the facility's investigation, looking at exposures to other patients, perhaps in the waiting room when they were there, or to the actual healthcare workers, as well as if they are a healthcare worker themselves, to coworkers. So we do that with all the medical type settings, and we look at, again, whether they had masks on or not, how close they were to that person, the time spent, and we process it down, deciding whether they're qualifying for that close contact where they would need quarantine. And so we also reach out with the long-term care process that I didn't mention earlier. When we have a positive healthcare worker or a resident, every single time we have a positive case, we reach back to that facility, whether it be a group home, long-term care, assisted care, basic care, and we go through any identifying of any close contacts, and again, review their processes they have in place to make sure we aren't missing anything from the type of screening they're doing to the type of PPE they're using, as well as when they take their breaks, how they take their breaks, their lunchroom setup, where they're storing their reusable PPE, the disinfectant they're using to make sure it meets kill claim for the human coronavirus, and that they actually know how to use the disinfectant. Every disinfectant has what we call a wet or a contact time, which means that product actually has to remain on that surface wet in order to, for that kill claim that they have to that virus, to make sure that wet time is being maintained to actually do the kill of the virus. We look at how they clean their facilities, the products they use, how the frequency of their cleaning. So we're kind of a pain in the butt to some of these facilities, but we do constant coaching and recommendations. And if they do have a little cluster and outbreak, we have team calls where we basically brainstorm, and they ask us questions and we ask them questions, because it's kind of like when you say having another set of eyes. And so that's what we're there for, is to prompt some more questions, review some things. The more we discuss, the more things we might find that we could improve on. Example would be for the masks. Normally they're wearing the surgical, or what we call face masks, in a healthcare setting, where us as the public people will be wearing cloth masks. There are some types of settings, like a chiropractor, for example, that might just wear the cloth mask. And so if you're a patient and you have your cloth mask and the chiropractor has his cloth mask, and your time to gather is longer than 15 minutes, and most chiropractor clinic offices are small offices, so you're meeting that within 6 feet, we would consider that a close contact, basically on that point, not only because of the distance that you're in close contact and the time, but also the level of filtration of the mask. So we have people that get upset when they're identified as a close contact because everybody had masks on. But we have to look at those mask types. And so cloth masks don't have as good a filtration as your surgical face mask. And then of course your N95 mask is a better filtration for your healthcare workers. And so under the, what they call the essential worker, we also review that person is truly essential. So it's not kind of like I don't have to isolate or quarantine because I'm an essential worker. You would still need to follow that quarantine, but may have the exception for the facility you work at to meet that essential worker guideline if they can truly not provide the services without you, where they can't staff any other way. So it's not, the essential worker is not meant to be, oh, I'm a nurse, I can work no matter what. So if you're a nurse, but there's extra people that can pull your shifts, we don't want you working as an essential worker. There are times where you do need to work because of the staffing situation, or because of an outbreak where there's so many positive people out. And our recommendation is to bump you up into that N95 mask then, because it's a better filtration than what normally facilities are using as the surgical face mask. So we look at all of that, and it's, everybody wants a black and white answer, but every situation is different. Again, we look at the type of PPE used, the different masks, the distance, actually what's occurring during that visit. If there's any kind of aerolization going on, whether there's a nebulizer treatment, or, if the person's very symptomatic and coughing, having a really strong cough, and it's a smaller room, but maybe a 12-foot room versus a 6-foot room, we would still probably, depending on the scenario, advise even the people that are outside that 6-foot distance to quarantine if they weren't wearing a mask and eye protection, versus just monitor yourselves. Because of the coughing, you're projecting those droplets further than just normally breathing or talking. So it's not like, oh, had a mask, good, you're good to go, you weren't exposed type situation. So I don't know if I answered that or maybe got off track, but do you have any other questions that I didn't cover? Or?
No, Faye, that was a great answer. I learn something from you every time we visit, and you're just a wealth of knowledge. So thank you for sharing that. Tasha, I have another question for you, and this one is touching on those positives that you mentioned at the end of your last answer. I want to hear from you about how has your community supported those who have found themselves in isolation or quarantine?
Right. So I think early on we, when I don't remember who it was talking about the homeless population, we did end up finding, not necessarily, I don't think they would identify themselves as homeless, but facing instability, I guess, housing instability. So people that are maybe staying with relatives, we were seeing that time and time again. And so once you test positive, then your family doesn't want you staying there anymore. So then you're essentially homeless at that time. And so we were utilizing some of those services that were being offered in the larger communities like Bismarck for the sheltering of homeless. And so, but quickly realized we have to have some plans for our own communities to be able to keep them here, for us to be able to provide services to them. And so one of the things the tribe worked on initially was sheltering locations for those individuals who were either in overcrowded homes or didn't have a place that they could safely isolate or quarantine. And so those are some, I know in one of our communities, they set up a quarantine camp and they had campers and basically, had security watching those areas so that people weren't trying to come and visit them or things like that, brought them food, checked in on them. And so that was something that we've seen early on, and it was really necessary, like I said, because these were people that didn't have any place to go. We've seen the tribes and local districts do have support available, financial support for food, cleaning supplies. We have thermometers. We do have pulse oximeters coming so that we can, when they are in that situation where they need to self-monitor at home, that they have the things that they need, because we were running into, some homes didn't have, and that's everywhere. Some homes didn't have a thermometer and you could not find one anywhere. You could not go to CVS and buy a thermometer for a while. So the tribe did get some of that stuff so that they have it available. There's been donations of like PPE, so masks, when these individuals are home, we're able to give them some masks. Sometimes we also have donations of like symptom relief kits that have Tylenol, just little packets of things that can be given as like care packages to the homes. We also have local organizations that have done, we did have one local organization that butchered buffalo and handed out buffalo meat to the families. And we've had other ones that have stepped up and paid utility bills for families that were at risk of having their lights shut off during their quarantine period. So we just have a lot of community organizations and entities that are pulling together to make sure that families can safely quarantine or isolate. And so, but we still are seeing a void. We still see a gap. So I know that there's more work to be done, but we have seen a tremendous outpour. And then also families. So we do have, we're really tight-knit communities and, really rely on family. And so we've seen that. We've seen where people are delivering food. We've seen, I've had family members making huge signs to hang on the door saying, in quarantine, do not visit, please stay away, those kinds of things, just out of love, to help keep everybody safe. They want their families to be safe, but they want other people to know, this is it's not a good idea to visit at this time. And so we've just seen a ton of community support. So it's been great. We've also had one of the areas, we had another group of just people in the community that were understanding that it's hard for kids to quarantine, right? Being stuck at home is hard for 14 to 24 days sometimes. And so we had our households that were requesting any kind of donations like movies, puzzles, books, and so we had a group of really proactive ladies in our community that started gathering those items and having them delivered to some of the communities. And so those are things that have been really heartwarming for me to see, because I know that we have people in our communities that really care and are there to take care of each other. So it's been really great.
I love hearing about all of that support, Tasha. Thank you for sharing that. Okay, Brenton, we're going to come back to you. COVID seems to not affect children as much as their older counterparts, which is great news. But because many children find themselves in daycare settings while mom and dad are at work, I'm wondering if you can talk a little bit about how you work with daycares to determine exposures when there's a case in a daycare, and then what constitutes recommending that a daycare close, and then do you have any best practices for daycares that you'd like to share with the participants?
So daycares. So daycares are kind of the bane of all of our existence. They're great. They provide great services to parents, and they're great, and they're 100% necessary. But they've been kind of a mess with COVID. You know, daycares are really hard because many of those kids are in a room, and it's really hard to control the actions of a kid. A 2, 3, 4-year-old, even a 5-year-old doesn't really understand, hey, I have to stay 6 feet away. I can't, play with my friends. And we don't want that. We want the kids playing with each other. We want the kids to have that social interaction. And that's why many parents, send their kids to daycare, is for that social interaction, so that their kids can get those social skills that benefit them so much later in life. So, cases started to appear in daycares early on. And, when we would have a daycare, you just kind of think, what happened? How do we prevent this from spreading through the daycare like wildfire? And one of those things is what we can do to help the daycares, and what we do, like we do in other situations, is we take out the positive case and those close contacts for 14 days. So if the daycare or exposure happened in the toddler room, the 2, 3, 4-year-old room, anyone in that room, anyone who would come into contact with that positive case, which typically we included the whole room and any staff in that room, would be quarantined for 14 days. What we did to work with the daycares is we worked with them to develop best practices. Best practices, daycares oftentimes in days past, hopefully not anymore, would have float teachers who would jump around and, cover breaks from room to room, maybe in the toddler room for an hour, maybe in the pre-K room for an hour, maybe in the infant room for 2 hours. If that float teacher tested positive, everyone in that facility would be considered a close contact because of that 6 feet for 15 minutes or more. So we really worked with daycares to help them come up with policies so that they didn't utilize a float teacher. Or, breaking down rooms or condensing rooms at the end of the night would be another situation where, you have 4 kids left in the pre-K room, couple kids left in the toddler room. Let's move them all together, so then you can potentially, limit the number of staff, let staff go home, but really that caused, potential exposures in multiple rooms. So we worked with them, to discourage that kind of practice, worked with them with cleaning, environmental cleaning, and we provided the education back to the parents as well when a positive case would appear in a room. We would provide a nice, lengthy letter talking to them about what to expect, what symptoms to look out for. We would let them know where they could go in for testing. And then we worked with them to let them know when they could go back to daycare. Kids may not have the same negative health outcomes as our older individuals or our homeless population or our other populations at risk. But we do know that kids can spread and do spread it. The CDC did recently come out with an MMWR, I believe, just over the weekend, talking about childcare facilities and their impact of spreading COVID. And then we do know that many young children, our 2 to 3-year-olds, have young parents who may still have grandparents. So these kids aren't only exposed to their parents, they are potentially exposing their grandparents and great-grandparents as well. So if they do come down with COVID, it's not only the children at risk, but they're potentially exposing others in the community that may not have the luxury of having a mild illness. So that's why we worked with the daycares, and we try to minimize exposure and come up with best practices.
Yeah, great answer. Thanks so much, Brenton. Shawn, the next question is for you. Your background in psychology and experience as a field epidemiologist, I think, has uniquely prepared you for dealing with those who maybe aren't so willing to cooperate with public health during a pandemic. I know when I was doing case management, I often asked you your opinion on how you would handle different situations. So I'm just wondering if you can share with the group some of your strategies for working with individuals who may not be so happy to talk to public health or cooperate with us during our case investigations and contact tracing.
Thanks for that question, Kylie. I've had a lot of opportunities to sharpen my interviewing skills, and actually in 2012 with that tuberculosis outbreak, I got an opportunity to interview a lot of folks who were essentially challenging case interviews due to different social circumstances or distrust of government. And I think that's something that we do run across as we do COVID investigations. Not necessarily everyone is resistant or doesn't want to cooperate, but I think everybody has kind of a sense of guardedness just as a baseline these days when you're getting a cold call from somebody out of the blue, whether they're with the government or not. I mean, we all experience or are very aware of scam calls or of all kinds of things. So I think that's one of the first things that we end up having to be concerned about when we contact someone is ensuring them that we are who we say we are and that we can keep their information confidential. That's one of the primary concerns that folks have is, what are you using this information for? Are you who you really say you are? And usually the strategy for that has been, if that comes up, we give them options that they can verify who we are. If they want to call us back, if they want to call a more official phone number, they can do that and get our information. And then we can touch base later, that type of a thing. Lots of times when people seem guarded or they tell us they don't want to share certain information, I just cut right to it and I ask, hey, let's talk about those concerns. What are you concerned about with sharing this type of information? Many of the skills that we use or that I encourage caseworkers to use are things like motivational interviewing. I think a good interview can actually get around a lot of the guardedness or when someone becomes more resistant, just as a baseline. And so that motivational interviewing, getting them to be kind of a partner in the process, encouraging them that they're assisting us in protecting the health of others. That's one strategy I like to use is how can let's work together to help protect the health of your friends, your family, and your community type of an approach. One question I like to start and encourage caseworkers to start an interview with is not kind of getting right into the nuts and bolts, but just asking them what concerns they may have, what questions they might have right away. Because if you don't get into that, that might be something that's sitting over the top of their interview. And it's a good way to build kind of rapport just off the start. So, hey, I'm calling and what can I do to help you? What questions or concerns do you have before we get into anything? I think it's kind of a way of extending this message that we're there to help them and we want to help others. And so, instead of asking questions, open-ended questions are very helpful. Because you're not diving into, it's not an interrogation. It's best to have a conversation with somebody. Take the time. I mean, there might be some that are short with you, and you need to get right to it. But most people, appreciate a little small talk or relating with somebody. Anytime I find a moment where I can relate to something somebody said, a quick just one line of how you relate to that or things can build rapport and can help keep a conversation going. And when you have open-ended questions that solicit a conversation, you can learn a lot more about a person and what they've been doing and the nature of their day and who they're around than you can if you're just kind of grilling them about, where were you at this time? What did you do next? Who do you know that you were within 6 feet for 15 minutes? We don't want to ask people to generate a list of close contacts by giving them the criteria. That makes them the contact tracer, right? And they're not the ones that should be doing that. So the other skill that I mentioned to caseworkers, one of the open-ended questions when I have been doing the mock interviews to try and train is instead of asking someone, so when did your symptoms start? Ask a question like, what brought you in for testing? Because with that open-ended question, they can tell you then about their symptoms or that they were exposed or they had this concern. And so they went in for testing. And from there, you can build off of those questions and get into things that might be important for your case investigation and identify places where intervention might need to take place. Another question I like to, or another tip I give the caseworkers is kind of imagine what you do when you lose your keys. You know, you kind of look around and you think like, where was I when I had them? You walk yourself through the moments where you had, or what you were doing before when you think you lost it. And that's kind of what a case interview should be. You know, don't use recall memory where you ask people to list everybody. Walk them through the day. Use episodic memory because that can prompt their memory more and they can think of other people. And as these things come up, just kind of lead them. You know, don't stop and ask them when they mention that they went somewhere. Ask, okay, so how did you get there? Did you ride with anybody? Who else went there? How many people were there when you got there? What kind of things were you guys doing? And one thing I try to discourage them from doing is, as soon as a contact is identified, trying to get every bit of information about that first person that they mentioned. You know, they say, I went to, you know, a barbecue with my friend Steve. It's okay. We don't need to get everything, Steve's whole story right away, because if you have somebody who might be guarded, or if you start asking really specific questions about Steve, you know, what's Steve's last name? What's his phone number? You know, how old is he? All of these things can seem like a grilling, and it can put people on guard. And what they usually would do then, instead of later, you know, it's hard. People generally don't want to be openly defiant. They're more of, you know, they would rather omit information. So then they don't have to tell you no. It's just their way of saying no in these case interviews. And so if they realize that you're going to be asking a ton of details about a case right away, there might be people that they're not interested in telling you about, that maybe for whatever reason, maybe there's an interaction there they don't want to tell you about, or maybe they're worried that person would be angry with you for sharing that information. And so I just kind of get an idea of what they were doing and who they were around. First names is all I really need, that first run through their infectious period. And I kind of try to walk them through each day. You know, sometimes there are people that, you know, they're like, well, I've been home, and it's hard to walk them through anything else, you know, but there's always those questions about, well, how did you get places? Did you have visitors? Tell me about, you know, that person that visited. Did someone else come with you? One of the things I learned actually during interviews with the TB outbreak was, when you interviewed somebody and you asked who they were with or when they were at some place, a lot of times they would tell you about the people that they were there to interact with, kind of their immediate social, the friend they were with. But they would neglect to say that that friend had a wife and 2 kids that were also there, because that wasn't somebody that they were thinking about and interacting with. And so those are kind of those expansion questions when you ask as well. Did anybody come with Steve? Things like that can give you an idea of who's all there. And then once I get through the infectious period, then I go back and I say, hey, you know, let's talk about this barbecue you went to. It sounds like, you know, you went with Steve. I think he's a close contact. Can we get more information about him? You know, what's his last name? And get the details then, because now you already have a list and a number of people that you're looking for and their information for. And it's a lot more difficult for someone to say, no, I don't want to tell you that. They might, you know, they've kind of already told you, and they're more willing to tell you that information. You've had a chance to establish rapport without being overly nosy to them or things like that. And so they're much more responsive in giving you that information. And I find that strategy to be most effective in getting contacts and understanding the context of those interactions. That's another mistake sometimes our new caseworkers make, is they don't have the context around the interaction, because they're more asking that criteria of 6 feet for 15 minutes, not understanding what was happening with that interaction and then making the determination based upon that context if it's a close contact or not. So that's kind of many of the tips that I recommend for caseworkers. And then it's funny because our system doesn't go through these things in the same order. I go through them differently. We have right at the front of the pages for the case interview, you know, we have some demographic information, and then we have health history information. I mean, those things are important for us to understand who's being impacted by COVID, how they're being affected, those types of things. But that's not the public health intervention side. And if you start diving into those, again, it seems nosy and it can be off-putting to some people. And it also can seem to some people, why are you doing this? This isn't useful. Why? I don't understand why you want this. And so I kind of call that the cleanup questions at the end. Now that we've kind of covered everything, your dates, your isolation, who might be your close contacts. Now let's just go through these kind of not less important, but different importance, you know, of the demographics and the health history stuff.
Lots of great tips in there, Shawn. Yeah, and I find myself going through the case interview in my head too. of some of those best practices. Okay, Faye, another question for you, and you touched on this a little bit in your last answer, but we know that the use of masks has been shown to reduce the transmission of COVID-19. We get lots of questions from cases and contacts asking why somebody is still a close contact if both individuals were wearing masks. Is there anything that you want to add to your answer, or anything that you would want to just share with the group that you didn't share before?
Again, I think they need to understand the different filtration of the different types of masks. And so, yeah, the cloth mask, when especially public assessments, and I don't work with those as much, so I don't have to explain that as often. So Brenton or Shawn may have a better response, as I work with the healthcare, where majority of the time they're face mask or the N95, but we do push for the patients, or even in nursing homes, if the residents can tolerate it, for them to have cloth masks as well, and for them to be laundered every day. And so again, it's just that extra barrier of protection. But if they're within 6 feet and for an extended period of time, you know, the cloth masks get damp and wet from us talking and perspiring and things. And you also have the concern of when have they been laundered last. And so CDC considers that, as far as the community risk assessment, to still be an exposure if there's a positive case. The risk is less, and that's a good thing, but it does, when we classify it as an exposure, it does trigger that quarantine. And I think that's what probably upsets people the most, is they were wearing their mask and now they're still going to be quarantined. And again, I don't work with the public people as much, because I'm working actually within the facilities, but Shawn and Brenton might have a better answer that makes more sense for the non-medical healthcare worker situations that I work with.
I could just add what I say in those situations is, usually I mention that it's great to wear the masks, it's important to do them, and hopefully that can prevent you from being sick. But because they're not as effective as healthcare workers with fitted masks and eye protection, all these other things, that it doesn't eliminate your exposure. It's kind of drawing the line between what's an exposure and then reducing your risk for becoming ill, and just kind of explaining that to them, that hopefully you won't get sick because you did this, that's great, but you're still potentially exposed.
Yeah, great answer, Shawn. Okay, so our last question is for Tasha. Tasha, as we were preparing for this panel last week, we talked about, you know, what message you would give somebody wondering, how can I help, or what can I do? You shared something that really stuck with me, and I'm wondering if you'll share that with all of our attendees today, along with just any advice that you have for the attendees.
Sure. You know, we know that this pandemic has disrupted all of our lives. You know, a lot of people look at having to be quarantined or isolated, you know, a burden, and it's inconvenient wearing masks. People don't, you know, a lot of people are just really upset. They're upset that people are still being infected. You know, there's a lot of issues around that. And one of the teachings that we have as Lakota people is being a good relative. And so that's something that we continually remind people, is that this is not fun. You know, we're all experiencing negative impacts because of it. There's a lot of negative stigma and shaming happening, but really this is a time for us to start to think outside of ourselves and think about what we need to do to ensure that our communities are safe, that people are taken care of when they do contract it or they have come in contact with it. So it's just really about those kinds of things. Like I said, being a good relative, and like we've had to remind people quite often, because it's such an inconvenience. People are angry and upset. And so there's a lot of, and we talked a little bit in preparing for this panel about the mental health piece of it too. I mentioned a little bit about the children, but we're seeing a lot of, you know, isolation is tough for a lot of people. When you talk about issues that people may have in regards to mental health. When you're having to be alone, when you can't leave your home, when you don't have the support systems in place, that's difficult as well. And then you put that negative stigma or people blaming and upset, that all is very difficult for people. And so the more we can send that message of being a good relative and having compassion, I think that will come out a lot better on the other side of this. So that would be something that I would like to share with the group, I guess.
Thank you, Tasha. Okay, at this point, I think we will open it up to the group for questions. If you have questions, you can feel free to type them in the chat box, or you can unmute your microphone and go ahead and ask one or multiple panelists if you have a question. So we'll open it up for questions.
Yeah, Kylie, this is Andrea, and I actually have a question for Brenton, who had thrown it out there at the beginning, trying to recruit for contact tracers. My question is, are there any prerequisites for being a contact tracer, or any requirements that you have in regards to age or experience, time of day that they're available?
So I'm not intimately involved in the hiring process, but we do ask that they have some sort of health background or some kind of awareness. We do want them to be able to be a little bit tech savvy, because we are using various computer programs such as Dynamics. We do hire nurses, people with bachelor's degrees and people with master's degrees. Your pay range is dependent on what kind of background you have. And then availability. Really, we would like someone to have probably that 15 to 20 hours a week minimum, so that they have some weekends and evening availability. And then we do have people who are working for 40 hours plus for us as well. So kind of a wide variety. Our contact tracing goes from 9 a.m. to 9 p.m., 7 days a week. So if you kind of have availability in those shifts, we schedule you for 3-hour shifts, but we can work with you in whatever your schedule is.
Thank you. And do we have any questions then from anyone out there in the audience? Feel free, as Kylie said, to type your questions into the chat box or unmute yourself and ask a question.
Hi, everybody. Thanks for the great presentation. Very informative. This is Amy Wermeyer. I'm in pharmacy practice. My question is just about contact tracing and isolating. I heard through the rumor mill that people who have close contact in their household who test positive, that they now need to quarantine for 24 days. And that was different than what I remembered reading elsewhere. So I was just curious if you have any explanation about that, and kind of if there are different circumstances that would necessitate that versus others that would not.
And I can jump in and answer this. So household contacts, we consider a person to be infectious throughout their entire isolation period. So a positive case, or someone who tests positive for COVID, is considered infectious from the 48 hours of onset up until 10 days after onset of symptoms, or 10 days after the test date if they're asymptomatic. So we consider that day 10 a potential infectious, them considered to be potentially infectious. So household contacts, if they don't go in and get tested, or if they continue to test negative, would have to quarantine for that positive household member's isolation period, plus an additional 14 days, which encompasses that entire incubation period for the virus. Therefore, potentially making it about 24 days or more.
Have you heard, so the person who asked me this question phrased it like this to me, so I'm curious if you have a comment about this. Wouldn't that encourage household contacts to go ahead and get infected then, because their total time of having to stay away would be less?
So the CDC does allow, if they're able to isolate effectively within the home, follow the close contact, but you know, it's really hard, and we do consider the household contacts the most at risk, just by the nature of living in the same house as someone. So household contacts or household cases probably may already have an asymptomatic infection. So we really encourage them to get tested. We don't necessarily encourage them to get infected because we don't know what negative health outcomes they could have, but we do encourage them to get tested because more than likely, based on the cases that we have, many of our household contacts do become positive somewhere down the road.
Okay,
So
and
if they're household contact and they isolate, so let's say it's 2 adults and they, one of them goes to live somewhere else or something, then that 24 days doesn't necessarily continue to apply. It's if they continue to have contact throughout that infectious period.
Exactly. You are exactly correct. So if they're able to isolate, in a camper or in a basement with a separate bathroom and separate bedroom, or in a lake home, or even go stay at a hotel, then they would follow that 14 days of close contact.
Got it. Thank you so much.
And I think we have a question from Mark Strand. And Dr. Strand, if you could clarify, you had asked, are we still able to cover contact tracing sufficiently? I'm assuming you mean, are you able to address all of the contact tracing that you need to in an adequate amount of time?
No, more so numbers. Are we able to cover it at this point, or do we have contacts and actual cases that are just too many and outside of the scale of what we can manage across the state right now?
I just mention that I think, we're keeping up and we're getting the cases done within, all of them within the day of them coming in. Now, as far as if that's sufficient, I think we have to also consider the staff work hours that are required to do that. There's a lot of extra hours and overtime that's being required to meet that demand. So I think there's kind of 2 ways of looking at that. One, cases are being completed and followed up within the day of their them becoming cases. Usually, I think within 4 to 8 hours. And then the other side of that is, are we able to do that while providing, I think, work conditions that are more conducive to a regular schedule, which I don't think we have been able to do that for at least the full-time disease control folks.
I think to also talk to your point, Dr. Strand, the Department of Health has brought on a number of additional contact tracers to handle this increase in casework. I know specifically at NDSU, we hired, I think it was almost 60 undergraduate students in the College of Pharmacy Nursing, Pharmacy Nursing Allied Sciences, and then graduate public health students to, address the workforce needs of the casework and contact tracing. So just at NDSU, we have a number of students that are helping, and like Brenton said earlier, UND has done the same. Local public health units are stepping up if need be, and then they have contact tracers that are just working for the state health department. All hands on deck, definitely.
And I think that might have to be our last question. I just wanted to thank all of the panelists. This was so incredibly interesting. Kylie, for organizing and contacting and organizing all of our panelists. Thank you so much. I know that Dr. Johnson does have some concluding comments for us.
So I want to thank Kylie and all of our panelists. This has been extremely interesting information on the inner workings and complexities of managing COVID and all these different settings. I learned a lot today. And so I also want to say thank you to all the participants for joining us today. So thank you again to everyone for joining us. It's been a great afternoon.